Patient's admitted to emergency department suffering a chest trauma. Patient's unconscious, cyanotic, and tachypnic. Has blood in his mouth and throat. Breath sounds reduced both sides. Physician requests that you intubate this patient, and the question is why. And again, the quote from John B. West, respiratory physiology is the lungs for gas exchange. Simply put, it's the complex physiology that goes on with that simple process that we're going to spend the next 16 weeks talking about. How boring is that? Just again, a distinction between ventilation and respiration. Ventilation is the bulk movement of gas in and out. Respiration is the exchange across tissues. Huge difference. So as I mentioned earlier about when you're in the ICU, you're dealing with ventilators. You're not dealing with respirators. Okay. But there's multiple other processes that go on there as far as a cardiopulmonary system. Bottom line is that our goal is to get oxygen to the mitochondria who need it for energy. Cell cannot function effectively without oxygen present. By the way, if it doesn't, we know that going back to that nasty Krebs cycle, there is a mechanism where anaerobic metabolism can occur, but it's not totally ineffective, but it's far less effective. The quantity of ATP that you create is 1/5 or 1/4 or something like that. Plus you create acids which do not do well for cellular function. Two terms that you need to be aware of. The first one being a reduced level of oxygen in the bloodstream, specifically the arterial bloodstream. Considering that's where the blood's going to the tissues, it'd be good to have enough in it to start with. The symbol for that is capital P, small a, O2, partial pressure of arterial oxygen, and that's when it's in the bloodstream. When it's reduced, we call that hypoxemia. No, how about just hypoxemia? Technically, I didn't mention this earlier, but if you have an elevated level above the normal range, we would call that hyperoxemia. At the tissue level, there's the reduction in the amount of oxygen is called hypoxia. And the reason why it's there is multiple. And when we get to that part of the course, we'll find out there's really 4 different types of hypoxia that are possible. One of which is a hypoxemic hypoxia. In other words, my oxygen levels in the cell are reduced simply because of reduced in the bloodstream. Now, ordinarily, if I make you hypoxemic because I force you to breathe oxygen or breathe a composition of gas that's less than the amount of oxygen that's in this atmosphere, your body's going to compensate for that by increasing the respiratory rate and increasing the heart rate. So it's going to try to fix the problem itself. There are times, though, where that is not possible. Where the amount of oxygen deprivation is so extreme that it cannot compensate for it. Or the compensatory mechanism's broken, as we'll find out. This is basically what promotes the development of anaerobic respiration, and as we know, that's problematic. So symbol is P, capital P, small a, O2. As far as ventilation is concerned, you need to, and when we get to the different portions of the course, you'll see where this will fit in, but there's really 3 components that exist. There is a trigger to begin a breath that occurs within the brain, specifically in the medulla oblongata, and to some extent within the pons region of the brain also. Those 2 centers initiate a breath, okay? That then travels down your spinal column through your central nervous system to the one specific nerve, the phrenic nerve, as we'll find, that innervates the diaphragm, which begins contraction of the muscles. And then finally, there needs to be some movement of that respiratory muscles to inflate the lungs and to promote gas exchange. Anywhere along there you got a problem, you're not going to be able to adequately ventilate the patient. What will end up happening is the amount of carbon dioxide in your arterial bloodstream will be elevated. We call that hypercarbia or hypercapnia. And the symbol, again, for that carbon dioxide in the arterial system is capital P, small a, CO2. Okay? But the lung only has 2 functions. Get in oxygen, get out carbon dioxide. Actually, that's a little bit of a misnomer. There's other things that go on kind of interestingly. But that's 2 primary things. Good air in, bad air out, right? So we'll leave it at that. We manage this process in the intensive care unit by placing an artificial airway. A couple of things that I kind of went through before. As we'll see, this tube is basically placed through the mouth into the trachea, and at the very tip of it there's a cuff that is inflated, a little pilot balloon that when we blow air in here, it inflates this balloon and seals the system off so that any air that enters in through here can only exit out through here. There's no leaking involved. If this cuff wasn't inflated, every time I would push air in through this portion, it would just leak back out, and blah, 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 blah. We'd end up hearing the patient gurgling as far as that is concerned. Okay. And as we'll see later on today, this is a laryngoscope, which is a device which is used to visualize the laryngeal structures and facilitate the placement of this tube into the trachea, because it's not an easy task to do. Preferentially, if I were to push this tube in, it's going to go right down this tube. What is that? That's the esophagus. Last time I looked, there's no alveoli inside your stomach. Okay, that organ is not designed for gas exchange. Well, if you're 14 and you drink a lot of pop, it probably is some gas exchange is going to come back up, but that's a whole separate issue. Alternatively, we can look at placing a tracheotomy tube, a tracheostomy tube, excuse me. Tracheotomy is a surgical procedure creating an opening into the trachea. Tracheostomy, an ostomy meaning an opening. Once that opening is there, maintaining that opening through placement of a tracheostomy tube. Semantics to some extent, but there is a differentiation. Tracheotomy being the procedure, tracheostomy being what is resulting from that procedure. And you can see the tube is placed, and it's actually below the vocal cords, as we'll find out later on. So in this case, when this tube is placed, as well as when this tube is placed, because this is going through the vocal cords, phonation is not possible. Patient can't speak. Opens up a whole other avenue. Intubation is the placement of the endotracheal tube. Extubation is the removal of that tube. So one goes in, one goes out. All right, so what we want to talk about then is the various anatomical structures that molecule of oxygen that's coming from the atmosphere has to pass through in order to get down to the alveolar capillary membrane and move into the bloodstream. Okay, there's a whole slew of things that are there. Just a brief review as far as the histology involved. There are 4 primary tissue types. The one we're going to focus on for today is the epithelial tissue, because that's the portion that is basically on the outside surface of not only your external skin, but lines all of your organ pathways along the way. It also has some glandular creation, or it's involved with some of the glands, and there are some specialized tissues that deal with moving stuff around. 3 primary epithelial cell types, a squamous, a cuboidal, and a columnar. Squamous being the first one. It basically think of it as surface area. They're flat pieces of paper that are there. They are primarily there for gas diffusion, at least as far as the simple squamous, where it's just one layer, and that's the one that is found within the alveolar capillary that line the alveolus, and we'll find it also line the capillary system. They're also in multiple layers, which is what would be on your external skin, and that's primarily there for protection. Cuboidal are fat little buggers that have a lot of volume in it, a lot of cytoplasm, which means there's a lot of metabolic activity. Not really great for diffusion, but they function for that other purpose. And then there's a columnar that are basically tall and thin, and they're usually associated with secretion or absorption of various substances. And again, they're thick, so they don't do really well for gas diffusion. As an aside to them, there's a pseudostratified columnar, which basically they look like they're multiple layers. They look like they're the stratified layer, but in reality, it's only one layer, and they're leave them at that. So those are the 3 that we end up dealing with. the simple squamous, simple cuboidal, simple columnar, the stratified epithelium where there are multiple layers, and then the pseudostratified columnar. This was out of Beachy, and basically I just want to point out a couple of things. First of all, this is a layer of mucus. As disgusting as that sounds, this is a cilia, which is a small hair-like projection that are on these pseudostratified columnar cells. So they become pseudostratified ciliated columnars. And what they do is these little hair-like projections whip this gel layer cephalad. So it moves it along the airway up until you're in the central airways where you clear your throat or your cough or you do whatever and you expel this mucus. The gel layer, so the sol layer is really watery to facilitate the movement of the cilia. The gel layer is real sticky. So as you inhale smoke particles or you inhale dust or fiberglass or whatever, it ends up getting trapped in the gel layer and being swept along so it's not pushed further down into the lungs. A couple other things, there's these goblet cells, which are just basically cells that produce this mucus in the process. That's their primary function. We'll also find, and we didn't talk about last time, but there's also some submucosal glands which are there that do the same primary function. Okay. So those goblet cells secrete mucus. That's the important part. Stratified squamous epithelium, which is primarily located in the oral pharynx, the laryngopharynx, and the anterior portion of the nasal cavity, the front of your nose. They're there for protection. The way to remember that is that's the portion by which little kids always do screwy things like put crayons in their nose and put army men in their mouth and everything else. You don't want that to have transmission of God knows what. So that stratified squamous protects that. The stratified columnar epithelium basically are the ones that are ciliated, as you can see. They have those hair-like projections. And they also are responsible for basically moving that mucus along. This is primarily in the back of the nose, where you have a lot of secretions, as well as a good portion of the tracheobronchial tree. And in simple cuboidal, which are located in the smaller airways we call bronchioles, and really they have a multiple function as far as secretion and infiltration. There's a special simple cuboidal cell that we'll talk about when we talk about the alveolar capillary junction, and these are called alveolar type 2 cells, and their primary role is secreting something called surfactant. We'll come back and visit that another day. But those are actually cuboidal cells located in the alveolar region. And then, of course, the most important cell, the alveolar type 1 cell, which are responsible for gas exchange. That type of cell is also present within the pulmonary capillaries. You know that the lung is the most important organ in the body, right? Heart, brain, trivial. Lung, important. Okay, so we got that cleared up. All right, let's talk about the upper airway. And it basically includes the nose, mouth, and laryngopharynx. And basically we're looking here that there's multiple processes involved. One, it's a conduction tube that is there. Ideally, it should be something that has a protective mechanism. So if you are, out late one night and you have a little bit too many Jack Daniels and Coke, and you become a little bit sleepy and obtunded, your upper airway should be a protective mechanism, that there should be some sort of a stimulus there so that you don't, do something stupid like vomit and inhale it. That would not be a good thing. Okay. It also has some other functions as far as smell and speech. The nose, primarily heat, humidify, and filter. Those three things are the three most important facets I want you to remember. The nose is responsible for warming the gas, regardless of the ambient temperature, and needs to be at body temperature by the time it reaches your lungs, basically. It needs to be also 100% humidified. The best humidifier in the world is your nose. It's a very, very effective mechanism of warming and moistening the gas. And it also needs a filter. There's all kind of crud in the air. You don't want to inhale it, so this gives us allows that process. And obviously, the sense of smell has a very is centered within the nose, as well as there is some speech function that does go on as far as resonation of certain sounds within the nose. Primarily, we're talking about bone and cartilage. The base of the nose is bone, where the majority of the nose, depending upon how large your nose is cartilaginous in support. Okay, there is a partition that runs along the center that is the nasal septum, and air enters into the nostrils or the nares, and then there's those two nasal passages called choanae, and the vibrissae are those that filter the incoming gas. Kind of like whiskers, but not really. The vibrissae are the nasal hairs that trap the large particles and become disgusting, and I don't want to go there. So the first third of the nose is a stratified squamous, which means protection. The back 2/3 is pseudostratified ciliated columnar epithelium, which means mucus secretion and movement of stuff along. Okay. There are some bony protrusions along the lateral wall that are called nasal turbinates or conchi, and that basically allows for that gas to be made that incoming airstream to be bounced around. Rather than being nice smooth airflow, what we call laminar, we want to make it rough and tumble. Because as it's rough and tumble, it's going to come in contact with the walls, and as it comes in contact, it's going to pick up humidity. It's going to pick up heat. Okay, so that's a primary mechanism that is there. There's also an extensive capillary network in the posterior 2/3 of your nose, and the capillaries that constrict or dilate regulate the blood flow that goes through there. Here's these conchi. There's multiple ones that are there, and as air comes in, it bounces around before it heads on down the nasopharynx, and that promotes the process of heat and humidification. Here's a deviated nasal septum. Really just want you to realize that multiple reasons why that can happen can be just congenital at birth, but it does not allow for airflow to be balanced throughout the nose and can lead to all kinds of problems, which is why we have that repaired in the process. Nice picture out of Beachy that is there that kind of highlights all of these, and again, you can see the conchi here up on top. And this is just talking about allergic rhinitis, and I know that they say about 10%, or no, it says 20%, but there's a fair amount of the percentage of population that has allergic rhinitis, meaning that during certain times of the year, certain allergens play havoc. You know, one of the things we'll talk about next time, we'll talk about this allergic reaction that happens because it's kind of central to what we do, and it's the body's response that's kind of gone haywire. And in this case, the body's responding to the fact that something, the allergen is present, and it's just secreting a whole bunch of mucus. Okay, that's a nice idea, only the problem is how you handling all of this, and which leads to the postnasal drip and the runny nose and the snotty, I shouldn't say snotty, it's kind of a bad thing to say, but you know, the problematic nasal discharge you end up having with that. The nose can filter particles down to about 5 microns. 5 microns is a pretty big particle. Okay, when we're talking about, just give you kind of a perception here, when we talk about cigarette smoke, the particles in cigarette smoke are down to about 0.1 microns. They're so small that they actually go in and come back out again, which is why we see when someone smokes the physical smoke stream that you end up having. But the nose is quite effective at filtering out particles, which is good, because you don't want some of those stuffs to be going in. I'll talk more about that later. The ability of the nose to function, to do its job, is impaired in 2 different instances, one of which is when we have a lot of mouth breathing going on, like we have when somebody exercises. They're moving large amounts of gas, can't move it through the nose because there's too much resistance to airflow, so we have to breathe through our mouth. In doing so, your ability to heat, humidify, and filter goes down. Nature of the beast. Also true when we place an artificial airway. So what that means is that when we intubate somebody, we're responsible for filtering, heating, and humidifying. Sometimes we do a great job at it, sometimes we don't, and that can lead into problems. The sinuses that are present are basically just some empty air spaces, and there's multiple ones that are there. You should have an idea just from A and P, the names of them. I'm not going to go through them, but they do have mucus-secreting goblet cells that are present that help to drain the nasal cavity. If you're lucky, if not, you end up with a lot of sinus issues, and they can become infected, as you're probably aware. And just some pictures of the sinuses that are there as far as their location. But again, that's back to A and P. There's just another view of the different sinuses and their proximity to the nasal cavity. All right, and as I mentioned, pet peeve, pharynx, not pharynx, okay? The N is after the Y, not before it. Drives me crazy. But there's 3 of these areas located: the nasopharynx, which is at the very back of the nose, the oropharynx, which is at the back of the oral cavity, and the laryngopharynx, which is proximal to the epiglottis. Okay. As far as the oral cavity is concerned, there's really 2 portions there: a hard and a soft palate. The hard part's the bony part, the soft part's the fleshy part, and the uvula is an example of what is present within the soft, or at the distal end of the soft palate. And we're not really entirely sure what the hell the uvula is for, but it looks kind of cool. The epithelium in this area is stratified squamous, and we know that that is there for protection. Okay? And this is also where the faucial tonsils are located on either side of the oral cavity. Here you can see a nice, wonderful uvula, and here's your tonsils. And this is what happens when they become inflamed. Kind of hard to ventilate if you got this big in the back of your throat, right? So that's where we do the thing called a tonsillectomy, where we physically go in and remove that structure. The purpose of them is primarily, or we think it's having to do with an immunological response, but they ain't doing a whole lot of good when they're that big and obstructing the process. The uvula can actually be a problem also, along with the tonsils and the adenoids, in that they can become very enlarged, and especially in patients who have what we call obstructive sleep apnea. You guys have probably heard of OSA. They can become so large that they actually go in and do what they call a uvulopalatal-pharynguloplasty. They go in kind of like a rotor-rooter and just cut everything out, with the hopes that it then will remove the amount of airway obstruction you can end up having. In OSA, somebody have a bed partner that snores heavily? Yeah, it seems like it's a benign thing. They're just snoring. Of course, probably if I took the pillow off my wife's face, that would probably would minimize that. But it actually can lead to some very, very serious health issues. Everything from heart failure through hypertension, through reduced blood oxygen levels, severe hypoxemia to the extent that you end up having a cardiac arrest secondary to it. Somebody remember John Candy, the actor? Uncle Buck, favorite movie. He died of a heart attack. No, he died of OSA. I have no doubt in my mind. The man was huge. And I'm sure he snored terribly. But there have been people who have had such severe obstructive sleep apnea. Had one guy we were doing a sleep study on. He had 50 apneic periods per hour, some lasting as long as 45 seconds. So he stopped breathing for 45 seconds at the extreme, 50 times an hour. When the hell was he breathing? Okay, so it can get very, very severe. Pardon me? It can cause all kind of stuff. Yeah, I mean, there's edema in what sense? Yeah, it's congestive heart failure. It backs up everything. A heart can't pump out, so it just backs it up into your periphery. Your legs swell. jugular venous distension, whole lot of processes. Yeah, just another view of the uvula and the palatine tonsils that are there. Nasopharynx, again, is located posterior to the nose, dealing again here with stratified ciliated columnar epithelium, which means secretions. These are also where your adenoids or your pharyngeal tonsils are located, as well as your eustachian tubes. Here you can see the pharyngeal tonsils in the back. The eustachian tube is basically that thing that connects to the middle ear and allows for allows for pressure equalization across the eardrum. We used to see a real complication of when this tube was blocked because of a nasal endotracheal tube, blocked off the eustachian opening, and there was a lot of ear infections. Don't use nasal tubes that much anymore, so it's less of an issue. But kids still get a lot of middle ear infections, and if it's pronounced enough, they'll go ahead and put in the drainage tubes, which basically help keep that eustachian tube patent. Oropharynx is basically that portion behind the oral. There's some linguinal tonsils that are there, and again, this is primarily stratified squamous for protection. That's a wonderful picture. Kind of a post-mortem view there of what we're looking at. But basically, this is the laryngopharynx at the base of the entry to the throat, where basically you have the esophagus on one side and the beginning of the upper airway on the opposite side. And this is also known as the hypopharynx. So if you see that terminology, they're interchangeable. Okay? So that's our upper airway as far as what we're dealing with as we go along. So again, here was our mini clinic where we're talking about after suffering chest trauma during a motor vehicle accident. They're unconscious, which means that you have a reduced amount of ability to clear your airway if need be. Whenever you lose consciousness, you often lose your gag and your cough reflex. That's not a good thing. This patient is also cyanotic, which is a very late sign, to be honest with you. And it's basically a bluish discoloration of the mucous membranes. And if you see a patient who's cyanotic, they're in a world of hurt. Okay. Tachypnic, meaning a rapid respiratory rate with blood in mouth and throat, so there basically is some maternal bleeding. And reduction in breath sounds means that they're breathing very shallow. I refer to this as breathing like a spaniel because you're breathing very rapid but very shallow. Very ineffective way to ventilate. Okay. And clinically, you'll see this all the time. It's a sign of impending failure that we need to do something with, meaning we need to place an artificial airway and mechanically ventilate this patient. All right. Let me go ahead then and move on to the next section. Questions on that upper airway stuff? We good with it? Okay. So now we're going to talk about that portion that goes from the beginning of the airways down through the alveoli. And this is really where the magic happens. Okay. Talk about the laryngeal structures, talk about the tracheobronchial tree, and eventually leading down to the gas exchanging units. But first.
Keine Sorge, wir finden Sie. Meine besten Leute arbeiten an dem Fall. Lassen Sie mich mit meiner Frau sprechen. Bitte noch eine Minute. Vivian, hast du eine Ahnung, wo meine Golfschläger sind? Du bist die Größte. Hey, who drinks Australian, thinks Australian.
How awful, right? It's there somewhere. Oh, there's my countdown. Okay. Kind of tissues in the posterior nasal cavity. Howdy, howdy, howdy. It's not calculating my percentages there. That's weird. Pseudostratified ciliated columnar. Secretion management. Which area is the most superior? I hate what he makes me think. And it is the nasopharynx. Inflammation of the inner ear, secondary to a blocked eustachian tube. Sounded good. All right. Here's our scenario. We're called to the emergency department to assist with the management of a patient during a code blue. Arrive as a physician is intubating a 47-year-old male who's in cardiac arrest. You auscultate the chest and you hear breath sounds only on the right. What should be done? Okay? All right. Let's talk about some of the upper airway structures. First of all, I want to talk about one that's not really technically part of the upper airway, but is necessary for everything else below it. It's called a hyoid bone. It's basically this bone which is located at the top here, and it is basically the thing that holds as an anchor all the laryngeal structures below it. The hyoid itself is attached via muscles to your to your jaw and your tongue. And basically, all of your laryngeal structures are just suspended beyond that. A little aside, when a coroner determines if somebody has been strangled, what they look for is a fracture of the hyoid bone, because that typically is what ends up happening during strangulation. So a little aside there. If you're strangling somebody, figure out a different way to do it. If we don't make up the hyoid bone, and that's kind of where it's located. And you can see then all the laryngeal structures are just kind of suspended, attached to it, kind of hanging there. The laryngeal structures, or the larynx, this is where phonation occurs, the voice box, also known as the voice box, but has multiple functions. One of the ones that we're going to concern ourselves with, beside the function of speech, is the prevention of aspiration. Okay, it's a conducting pathway. So as that oxygen molecule has now passed through the nasopharynx, been bounced around in the conchae and the turbinates, and goes ahead and continues on down into the trachea or into the larynx, it passes through the laryngeal structures. It also has the ability to create pressure changes, as we'll find. I'll talk about that in a second. The term aspiration basically is talking about the movement of stuff that doesn't belong in the trachea into the trachea. So under ordinary conditions, you should not be having fluid enter in. Okay? The larynx's job is to keep it out. Okay? Usually, if there is aspiration that does occur, there usually is a coughing or choking that is associated with preventing it. It's basically our mechanism to try and keep it intact. You guys have all went down the wrong pipe, right? Yeah, that's what we're talking about here. If you end up having large amounts of materials that are very caustic, and a perfect example is vomit, because its gastric contents, it's very acidic, and it can do huge damage, causing all kind of what we're calling pneumonitis within the lungs themselves, and significant lung damage with high mortality. So it's not a good thing. Who's at risk? Little kids, old people. Obviously, having a recent meal puts you at a higher risk. Anything that's going to delay gastric emptying, like a lot of medications might. Loss of consciousness or reduced consciousness, or patients with poor motor control, as you might see in somebody who has had a stroke and doesn't have a good swallowing function. Will all put you at a higher risk for aspiration, and we need to be aware of that. All right. Within the larynx itself, there are 9 cartilages. 9 cartilages. I sound like the principal in Ferris Bueller's Day Off. 9 cartilages. 3 of them are unpaired. 3 of them are paired. Okay, so you should be able to tell me who the paired ones are and who the unpaired ones are. Okay. The 3 unpaired are the thyroid, cricoid, and epiglottis. We'll go through them individually. And there's 3 paired cartilages for a total of 6. The arytenoids, the corniculates, and the cuneiforms. Okay. So this is an anterior and a posterior view. I believe this is out of Beachy or out of Egan, one of the two. It is Beachy, page 8. There we go. How's that? Here's my hyoid bone, and there's a ligament that then suspends my thyroid, my cricoid below it, and if we look on the back side, you can see the arytenoids, the corniculates, and the cuneiforms there. I don't show the cuneiforms really well, but they're there also. Okay. Thyroid, cricoid, epiglottis. 3 unpaired. Corniculate, arytenoids, and no cuneiforms, but they are there. This is what the airway would look like if we were to visualize it from our vantage point. Here's my tongue. Okay, so this would be the patient who's basically, this is anterior, this is posterior, pointing downward. And as we visualize, we see the epiglottis, we see our arytenoids and our cuneiforms and our corniculates. That's these paired cartilages, 1, 2, 3, 1, 2, 3. Can't see the cricoid because it's below, but that's primarily the epiglottis, and the thyroid and the cricoid are through that opening. These are your vocal cords, okay, that open up or close as need be. And here's this is a drawing, this is an actual visualization of that same process. Notice that they're shaped in the shape of a V, okay, in normal conditions. Arytenoid, cuneiform, corniculate. Just another drawing of that. You can see the epiglottis sitting there, and the thyroid below it, and the cricoid below that. Okay, what ends up happening is as you swallow, this epiglottis flops over and blocks that opening. So as you swallow, you can actually see physically your throat moving up and out, and that's basically that epiglottis closing downward, and that prevents that icky stuff from entering into your trachea. There's no reason that bolus of food needs to go down your lungs. Okay? It's kind of not the way that we were designed. Here's an x-ray that's showing some of the structures. And you can see, let's see here, here's my epiglottis. You can't, but look at the dental work, eh? No. So those paired cartilages, the arytenoids, the cuneiforms, and the corniculates. All I want you to know about them is they have to deal with phonation. They move the vocal cords so that you can speak. I don't care how they move, what they do. This is looking at the arytenoid cartilages, how they move. The cricoarytenoids, how they move. Lateral, blah, 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 blah. They deal with speech. End of discussion. Fair? Okay. Because you can get really into how they pull the vocal cords one way or the other. We're not going to worry about it. Simply put, they move to allow us to open and shut the vocal cords in some fashion to create speech, primarily. Thyroid cartilage, also known as the Adam's apple, more prominent on males and females, but both of us have them. Okay? It has a superior border with a V-shaped notch, so you can always find the thyroid because it has a little notch on the top of it. Okay? It is suspended from the hyoid bone through some ligaments and I'm going to say muscles because they're not. They're ligaments. The posterior portion of this is empty. So if I would turn that around, there's nothing on the back side. Okay? Only the anterior surface of it is there. And this is where your vocal cords, and there actually are two sets. There's a true set of vocal cords and a false set of vocal cords. False set are really not vocal cords, they're just pieces of tissue that are there. But they're located behind this thyroid. So this is basically what we would think of as the voice box, where your vocal cords and all those arytenoids and cuneiforms and corniculates are behind it. So it's the protective mechanism that is there. The V-shaped notch. Yes, ma'am. Not that I'm aware of. There probably is, but ain't important to us if that's the case. And there you go. The opening between the vocal cords is called the rhymaglotitis or glottis. So when I talk about the glottic opening, I'm talking about the space between the vocal cords. Okay? And this is the narrowest portion of the adult airway. So that's the smallest part of the, at least as far as the upper airway is or I shouldn't say that. Prior to entering into the trachea, that's the smallest portion that we're dealing with. Okay? The glottic opening. And here we can end up seeing the false cords and the true cords. And basically, this is kind of a cutaway, sagittal cut. But here's my epiglottis up on top that would flop down, close over that opening. And there's my vocal cords that are controlled by the arytenoid, cuneiform, and corniculate cartilages. And then we continue on down into the trachea. You can see how narrow it can end up getting. There are two positions that you can end up having. The vocal cords can be abducted, which means that they are moving away from the midline, or they can be adducted, which means that they are coming together. During the inspiratory phase is when they are abducted. During exhalation, or when we need to do things like cough and create a Valsalva maneuver or whatever, they become adducted. Let me see what this is.
This is how a normal voice box sounds. Please do not smoke.
It takes a second to load, but it's pretty cool. You can see the arytenoid and cuneiform cartilages, corniculates moving those vocal cords around. Okay? Here would be my tongue and my epiglottis. They're moving. That's a normal larynx. All right, you can stop now. Didn't want to do that. Let me take a look at one that's abnormal. Okay, where something has happened to cause the larynx to not be in a normal state. Where the heck are they? No, that's not what I want to do. No, that's not it either. I forgot where I needed to go to. Isn't it terrible? There we go. So here's a laryngeal cancer. Person talking. You can see this huge tumor that is sitting there. Okay, so that's going to affect the ability of the vocal cords to adequately move, which is the reason why you end up seeing such a severe. Can't get a good seal on exhalations because that area is just eroded away. That was interesting. You find these are all cancers here. There we go. Here's an example of just a polyp which is located.
This is how my voice sounds. Please do not smoke.
And if we look at a video of that larynx. Some huge polyps that are there. It doesn't allow for effective movement of those vocal cords. I wanted to find one that was a vocal cord paralysis. See if I can find it here. There we go. And this one, we're going to see that there's only movement of one vocal cord.
This is how my voice box sounds. Please do not smoke.
See it? Doesn't allow for effective speech or effective function of the laryngeal structures. Okay. Thank you for singing. All right, so easy way to remember abducted, adducted. When they're open, we say it's abducted. And the key part is that the B and the D, the vertical lines are opposite, or away from each other. Okay? Adducted, they're added together, they're next to each other. So you should be able to distinction between what occurs. During inspiratory phase, it would have to be abducted. When the patient, at the end of exhalation or for reasons that they need to have a closed glottic opening, they'd be adducted.
So if you're trying to intubate,
You would hope that they would be abducted. You betcha. And there's your open or abducted cords. Okay. The epiglottis looks like a spoon. It's at the base of the tongue. And there is a small space that is located between the epiglottis and the tongue that is called the vallecula. Vallecula. It's an important anatomical landmark that we'll need when we talk about intubation. And that's where it's located at the base of the tongue, right where the epiglottis and the tongue are joined. So when we go around intubating patients, we're going to use a device called a laryngoscope that allows us to visualize those structures, visualize the vocal cords, so we know where we're putting the endotracheal tube. It's very easy to put it into the esophagus. It's a little more complex trying to put it into the trachea. Okay? We basically have a device that has one universal handle and an option of one or two or more blades. There's either a curved blade, called a Macintosh, or a straight blade, which is typically a Miller blade. Macintosh is an apple. Apples are round or curved. Makes sense to me. Okay? Which blade you use is which blade you learned with. Okay? Does it make a difference? Not in the slightest. Okay? If you learned on a curve, you'll always use a curved. If you learned with a straight, you'll always use a straight. Now, theoretically, you should be able to use either, but most people who intubate frequently have a preference. Okay? Now, an exception to that is neonatal medicine. Neonates have epiglottises, epiglotti, I don't know what the plural of that would be, that are like these little floppy things. And the curved blades, don't work too well. So in neonatal, we're intubating those premature babies, we're going to be intubating with a straight blade only. Okay. So here's a picture of a universal handle. Doesn't make a difference. And inside the handle, by the way, are batteries, an important facet. And then there's a curved blade and a straight blade. And when properly attached, they'll come to a 90-degree angle and the light will come on. There's a little lamp at the very distal end. So what that allows us to do is see the laryngeal structures, to visualize the larynx. With the curved blade, the blade is slid along the tongue until it reaches the vallecula, and then as you lift the vallecula, you lift the epiglottis, because it's a kind of an attached mechanism there. It's an indirect way of viewing the larynx. The straight blade is designed to go in and directly pick up the epiglottis, so as we could see in some of those videos, you can then visualize the laryngeal structures. Indirect method with a Macintosh or a curved blade, direct lifting of the epiglottis with a straight blade. Okay? Distinction between the two. So let's say about, let's do this. Let's take 5. Okay, moving on to the rest of the last cartilage that we didn't talk about, and that's the cricoid. The cricoid is a cartilage that resembles a signet ring. If you don't know what a signet ring is, it's a class ring. Okay, where it basically is very wide in the front and very narrow in the back. Okay, it's inferior to the thyroid, so it's right below it. It is, big star by this one, the only complete ring of the laryngeal structures. Everything else is C-shaped. Okay? From the thyroid cartilage on through to the trachea, they're all C-shaped rings. The only complete ring is the cricoid. Okay? Inferior to the cricoid is the first tracheal ring, so it's the ending part of the laryngeal structures. Okay? This portion is the narrowest portion in the infant, where the rhinoglottitis or glottic opening was the narrowest portion in the adult of the laryngeal airways. This area is the narrowest in the infant. Okay. When we ventilate infants and neonates, and small pediatric patients for that matter, we don't use a cuff on the tubes. At least typically we don't. We just use the fact that that narrowest portion is there that the tube is going through. We allow a little bit of a leak, but it helps to seal it off by going through that space. Okay, here's my cricoid cartilage. There is a small portion of a small ligament that exists between the thyroid and the cricoid cartilage. This is called a cricothyroid membrane. Cricothyroid membrane. or ligament, and basically that is the space through which we can do an emergency access to that airway. Okay? It's called a cricothyrotomy, and if you're got nothing else to go on, you're going to end up doing a cricoid puncture. Okay? In theory, this is my cricothyrotomy kit. Puncture. Insert, and I have an airway. Okay. If I'm at a hockey game and somebody gets hit in the throat with a hockey puck, crushes the larynx, there's no air movement between the two, that's the only access you got. Okay. So we'll talk more about that as time goes on, but it's a drastic measure, but it is an accessible point through which, because above it may be destroyed, and quite probably will be. And this is a little kit that is present you can end up doing, where you puncture the cricothyroid membrane and you put one of these introducers in to be able to maintain patency of that airway. The laryngeal structures can end up becoming swollen, either subglottic or supraglottic. And they create a sound called stridor, which is a high-pitched crowing, heard during the inspiratory phase. And we see this with croup and epiglottitis, but also with foreign body aspirates. Let me give you a little sign of what this sounds like. Because once you hear it, you'll know it. Come in. So there's a little bit of problem moving air through it. Okay? And usually, in the case of croup at least, you'll hear the proverbial croupy cough, which if any of you folks have kids that have had croup, you know what that little bark sounds like. And here's a video of a little baby who's having it. I don't know if you can see it real well, but look at the substernal retractions. The sternum moving inward. Okay? Along with the stridorous sound. So it's basically a lot of energy is being expended to get a breath. Well, obviously, it's not going to last for very long. Okay? Hello, baby. Okay. Those laryngeal structures, the vocal cords themselves, the muscles that support them, can end up going into a spasm. Okay, it's called laryngospasm. This is actually a mechanism which can be beneficial. For instance, drowning victims, some of them will end up having, I should say near drowning victims, because if you're drowned, you're dead. If you're near drowning, you live. But you can end up having what is called a dry drowning, where the larynx goes into spasm, those vocal cords snap shut, and you don't have water entering into the tracheobronchial tree. Okay? It's also there as a protective mechanism. If you're home cleaning and you decide to be brilliant and say, you know what, ammonia cleans really well and bleach cleans really well, let's mix them together. Bad news. That creates a chlorine gas, and your larynx goes, what the hell did you just do? Snap shut. Okay, and you have these fits of coughing. Same is true with smoke inhalation. It's a body's protective mechanism that is there. We see laryngospasm after we pull that endotracheal tube back out. If you think about it, that tube is sitting between those vocal cords for a prolonged period of time, sometimes days, sometimes weeks. When that finally comes back out again, it can trigger those muscles to spasm. And in that process, the patient doesn't ventilate really well. Okay, so we need to do something to reduce that upper airway edema and swelling and that inflammation, and there's a medication we can utilize for that. One of the functions of the glottic closing is to create pressure. And if you've never heard of the Valsalva maneuver, it's basically where you take a deep breath in, and you close your glottis and try to force the gas back out. Okay, it's a mechanism that is needed for certain things like defecation. Kind of you need to build up some pressure in your abdominal cavity to facilitate that process. We also use it to clear the inner ear. Okay, but it's also used for doing physical work. Ideally, you're doing it when you're lifting or you're pushing something. Unfortunately, when you're vomiting. And that wonderful thing called parturition. What's parturition? Anybody know? Childbirth. Okay, it's the process that you need to create large amounts of intrathoracic, or you create a large intrathoracic pressure to push the diaphragm down and push the little bugger out of its hiding spot. Just a couple of things related to the head position. Normally, you end up having a neutral position where there's a straight line that goes from your upper airway down through your lower airway. When you flex your head forward, flexion of the head leads to closure of the upper airway, and that's why when we're doing things like CPR, we actually extend or hyperextend the airway. We'll also, when we're positioning somebody for intubation, we'll place them into an hyperextended position, what we typically call the sniffing position. When you are making that wonderful soup, what do? You lean your head forward and stick your head out, because it gets a much more direct pathway. When we're intubating somebody, we'll do exactly the same thing. We'll position their head so they're hyperextended forward, pulls the trachea anteriorly, makes the airway more in line, especially when you have an anterior placed laryngeal structures. Flexed, extended. Okay, so you should distinguish between the two.
That's somewhere with CPR.
That's exactly correct. We open the airway by doing a hyperextension of the air, of the head. And our Resusci Annie just rip her head back. Did you ever notice that Resusci Annie was always in running gear? Doesn't that make you wonder? We're doing CPR on somebody who's exercising. I'm just saying. Just throwing it out there. Here again is our endotracheal tube being placed, and you can see that it's placed into the trachea through the laryngeal structures and ends up in the trachea itself. What's that? Hard palate? Yep. And what's that? Esophagus. That's the cuff on the end of the tracheal tube. All right, above the vocal cords, we have a stratified squamous epithelium in the laryngopharynx and the oropharynx. Below the vocal cords, really pretty much all the way down is that pseudostratified ciliated columnar epithelium. So we're going to see a lot of mucus secretion being done from here on downward. Oh, I love this one. Melissa Williamson, the Bullitt Avenue resident, worries about the effect of her unborn child on the sound of jackhammers. Brilliant. All right, this is what we're going to look at now. Isn't that a pretty picture? That's basically if you took all of the meat and only looked at the airways themselves. The lung, as we'll find, is made up of two components. It's made up of airways, and it's made up of what we're going to call the parenchyma. The airways are, if you want to think of it, are the tree and all of its branches. The parenchyma are all the leaves. So if we took the lung and just basically stripped all the meat off of it, this is what we would be left with.
It looks like roots to me.
It does look like roots, okay? But if I turn it upside down, it looks like a tree. We don't call it the tracheobronchial root. We call it tracheobronchial tree.
If you see a tree, though.
No, that's true. You are correct. You are correct.
The roots are as big as a tree.
Yep. And we'll find that the lung is awful damn big when we get down to how large the surface area we're dealing with is. Regarding that tracheobronchial tree, there's two divisions to it. The first one are those that which have cartilage supporting it. We call the cartilaginous airways. These are there only for gas transmission, gas movement. They're conducting airways. There's no gas exchange within them. So your trachea, your bronchi, your bronchioles, only thing they're there for is to move gas. The non-cartilaginous airways are basically the ones that are distal to that, and these do have alveoli or alveolar pouches branching from them. So there is some gas exchanging in the non-cartilaginous airways as they go. As a tube branches, it branches into two daughter branches, which branches into two daughter branches, which branches into two daughter branches, blah, 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 and it keeps branching and branching and branching as you go down. That division is what we call a bifurcation. So basically, each bifurcation creates another generation of airways. As they divide, they become shorter in distance, narrower in width, and there's more of them, obviously. Each time they branch, they exponentially go up in the number of airways there are. As they get larger and larger, that means there's more surface area as far as the space within them. So here we have zone 0, which is the trachea, bifurcates, 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 blah, 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 until you get down to the 23rd generation, which is considered the alveolar structures. Okay? These are conducting, these are respiratory. The conducting only transfer gas. The respiratory zones are where you actually have gas exchanging units, and you can see the little alveolar pouches that are there. Okay, this is a picture out of, I don't know where. It's painful. What I want to just point out is a couple of things. As the generations get higher and higher and higher, the airways actually get smaller, 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 but the overall surface area, if you added them all up together, are actually bigger. Okay? So as we go further and further down the tracheobronchial tree, the resistance to airflow actually goes down. It's actually higher in the upper airways than it is in the lower airways. And I'll come back and talk about that in a little bit. Okay, cartilaginous airways, your primary ones that we deal with here. Going to look at the trachea, then branching into two main stem bronchi, branching into lobar bronchi, and eventually branching into segmental bronchi. Let's talk about the trachea first, where we start from. Somewhere around 11 to 13 centimeters long, and probably at 1.5 to 2.5 centimeters wide, so about the size of a quarter. It extends from the cricoid cartilage, right? We said the cricoid cartilage is adjacent to the first tracheal ring, and goes down to about the second costal cartilage, okay, or the 5th thoracic vertebrae. If you were to look at a chest x-ray, it goes from about the 6th cervical vertebrae down to the 5th thoracic vertebrae. So it's a pretty long structure, not that long, but that we're dealing with. Roughly 15 to 20 C-shaped rings, where the posterior wall of this is basically contiguous with the esophagus. And this will come into play in a couple different fashions when we talk about congenital defects where there's actual connections between the trachea and the esophagus that isn't always good. Or we end up having an endotracheal tube cuff that is leading to an erosion between the trachea and the esophagus, which is not good either. Okay. At the end of the trachea, at the end of those 15 to 20 rings, is the first bifurcation that we have leading to zone 1. This bifurcation is known as the carina, and the carina is the spot at which it branches into the right and left main stem bronchus. Just distal to that point, the air that we inspire has been warmed to body temp and has been saturated 100% saturation. So it doesn't take a huge amount of distance that the body has the mechanism by which it warms and heats it to where it needs to be. Pretty phenomenal set of structures there. That carina is located at about T5, if we were to look at a chest x-ray. And it's what we're going to call the angle of Lewis, and I'll talk more about that when we talk about bony structures of the thorax. It's important because if the endotracheal tube is past the carina, what does that mean? It's in one of the mainstem. Oops. That means I'm only ventilating one lung. Oops. Okay, we don't want that to happen. Okay. That tracheostomy that we talked about previously, that surgical incision, is typically done between the second and third tracheal ring. So it's pretty high in the trachea. Okay. In actuality, if you think about it, probably the last 8 or 9 tracheal rings is actually inside the thoracic cavity through what we call the operculum, which is the opening, that rounded opening of the thorax. It's just kind of hanging in there. Here's what the tracheal cartilage would look like. You can see I got this tracheal wall here. I have an interior epithelial lining, which is what kind of tissue? Okay, pseudostratified ciliated columnar epithelium, all the way down. And you can see that you have basically a trachealis muscle and then the esophagus behind it. So there's not much separating the two structures. Generation 1, mainstem. I now have branched from the trachea into my 2 mainstem bronchi. They're uniquely named, the right mainstem and the left mainstem. Whew, that was easy. Okay, one for each lung. Kind of works that way. The right mainstem is a little bit wider, a little bit shorter, and a little more vertical. It branches at a different angle than the left mainstem, which is a little bit more of an acute angle. Okay. When we're infants, where it's a little bit different, we're pretty much even, but as we age, we end up having a little more of an acute branching into the right as opposed to the left. Who cares? Well, if you inhale something, where's it going to go? In the right side. One of my buddies, I always tell this story, she loves me for it. She's a respiratory therapist. In fact, she has my position at Mock Community College. She was drinking Sambuca with the little coffee beans in it, you know, and somebody was telling a joke, and she laughed and inhaled the coffee bean. Where'd it go? Right main stem. It actually went down to one of her lobar bronchi, as we'll see next, and lodged there. And she developed a little bit of a pneumonia because that airflow was not working really well, and they were on the verge of actually going in and removing it when she coughed it out. So the moral of the story is, forget the coffee beans and the Sambuca. And again, newborns are pretty much even, but for adult purposes. Preferentially, if I place an endotracheal tube and I push it in too far, it's going to go in the right main stem. Okay? So that's what we're talking about here. During an intubation, there's 3 options you have. One, you put it into the trachea and it's in the right spot. Bitchin', we're all happy. I see lungs inflating equally on opposite sides, on both sides rather. If I push it in too far and it actually goes past that carina and into the right main stem, I'm only going to have breath sounds on the right side. So what I need to do is just pull the tube back. Pull it back a centimeter or so and verify bilateral breath sounds. Make sense? If I don't hear any breath sounds, that means I'm not in the trachea. It means I put the tube in the esophagus. And if you were to listen over the epigastrum, you would actually hear gurgling in the stomach. Okay? In that case, no matter amount of pulling it back is going to help. I got to pull it out and try again. Okay? So there's 3 options. Bilateral breath sounds, everything's cool. Breath sounds only on one side, typically the right. Pull it back and then reassess. No breath sounds at all, pull it out and start all over again. Got it? That might make a good test question. Just saying. Okay, and we talked about foreign body aspirates, how they typically go into the right main stem as opposed to the left. And what you end up with having there is that wheezing sound or that hoarse sound you would probably only hear on one side. Generation 2, lobar. So we've gone trachea, main stem. Now we go to lobar. And they're basically correlated to the number of lobes within our lung. Okay, the right side will divide into 3. The right upper lobe, the right middle lobe, and the right lower lobe. Whew, damn, that was easy. On the left side, it divides into 2. The left upper lobe and the left lower lobe. Why does the left only have 2 and the right has 3? That's damn hard. Just getting in the flipping way, you know? It's taking up space. So we only have 2 lobes as opposed to 3. So, 1 trachea, 2 main stem, 5 lobar. Segmental, generation 3. Hibbity, 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 hib. Okay? There are 18 segments, 18 different branches off of those lobars. 10 on the right, 8 on the left. Okay? So, 1 trachea, 2 lobar, 1 trachea, 2 main stem, 5 lobar, 18 segmental. And that's about as far down as we can look with a device called a bronchoscope. Okay? So if a physician wants to go in and visualize the airway structure, they can only get down typically to about the segmental level. Beyond that, they start getting too small. 1 to 4 millimeters in diameter. If you pull out your ruler and look at a millimeter, that's damn small. Okay? But those are the subsegmental bronchi. So you keep branching and branching and branching and branching. Along with that branching is not only the airway branching, but also the nerve, the lymphatics, and the bronchial arteries. The bronchial arteries being the structures that supply blood flow to these branches. And they keep branching in the subsegmental bronchi. So here's my trachea, main stem, and you can see how the coloration of a lobar, these are lobar, but then the segmental are different colors. I believe that's out of your book somewhere. Then we keep branching. Now we've gone from trachea, main stem bronchi, lobar bronchi, segmental bronchi, subsegmental bronchi, to bronchioles. Okay? And these are basically continuing on to the 10th to the 15th generation. You don't really need to know those numbers, but just so you can get an idea of how far down we're going. Now we're down to about 1 millimeter in diameter. Now we're starting to lose the ability of the ciliated tissue. We also lose cartilage. Whenever you see the oles, that means you no longer have cartilaginous support. Starts to get important when we start talking about airway collapse. If there's nothing there to hold the airway open, it's more prone to collapse. Okay? So the bronchioles continue, and then we get to the final conduction component, which is called the terminal bronchiole. And these are about 0.5 millimeter in support. Again, no cartilage, losing the cilia, losing the pseudostratified columnar epithelium. And one thing that I want you to know is this concept of a canal of Lambert. These are connections between adjacent bronchioles. So let's say I'm going down my tracheal bronchial tree and I get to these terminal bronchioles and this bronchiole is collapsed. Well, everything distal to that is not going to be able to be inflated, right? Well, the body says, wait a minute, this is stupid. If this other one is open, why don't I make a connection to go around that obstruction? It's basically a detour that is created. Between bronchioles are called canals of Lambert. Okay? So it's an alternative pathway that exists. Now, you'd think that the terminal bronchioles are the end of the line. No. There's a last of the conducting airways. What's after them, and there's my canals of Lambert, what is after them is all the gas exchanging units. Now, all the way up to this point in time, you need something to feed oxygen and nutrients and remove waste parts to those vessels. And this is where the bronchial arteries come in. Bronchial arteries nourish the tracheal bronchial tree up until this point in time. The bronchial arteries arise from the aorta, and they basically follow the branching all the way down to the terminal bronchioles. Past that point, because we now have gas exchanging units, the supply of oxygen and nutrients is done by the pulmonary arteries. So that's where the transition happens, is when we start seeing gas exchange happening, the supply of nutrients to those tissues is no longer through the bronchial arteries. Okay? If you look at the amount of blood flow, 1% of cardiac output. Damn efficient structure. Okay? The amount of energy that the lungs utilize is very small. Heart.
Off the aorta, bronchial arteries.
Correct.
Gas status.
It keeps branching along with the airways and it gets to the terminal bronchioles. Beyond that, it's the pulmonary artery that is feeding the tissues. Okay, but it's a very efficient structure. Heart, brain, pigs. Lungs, cool. Okay. And the bronchial arteries also supply some of the lymph nodes and nerves and all those other things associated with that. So this is the generations that we've gone. Generation 0 trachea, main stem, lobar, segmental, subsegmental, bronchioles, and terminal bronchioles. Whew. Branch, 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 branch. Now we get to the cool part. Now we get to the respiratory zone. Okay? This basically is everything distal to the terminal bronchiole, which includes the respiratory bronchioles, structures called alveolar ducts, alveolar sacs, and individual alveoli. Collectively, these are known as the acinus or the primary lobule. If I mention the kidney, what's the functional unit of the kidney called? The nephron. That's the kidney. We don't need to know about that. That's the lungs. No. We'll talk about how the kidney interacts with the lungs later on in life. But the nephron's the functional unit of the kidney. The primary lobule, or acinus, let me say that word again for you. Acinus is the primary functional unit of the lung. If you put all of the primary lobules, or acini, together, we call that parenchyma. That's the meat. Where the tracheobronchial tree is the bone, this is the meat that surrounds it. If the trees are the branches, these are the leaves. Okay? And this is kind of where it's located. And this, Beachy does it wrong. He has this picture where he's showing the respiratory zone, including the terminal bronchiole. It does not. It's everything distal to it. So the respiratory bronchioles, which have little outpouchings, alveolar ducts, alveolar sacs, and individual alveoli. They're all gas exchanging units. They're all where the magic happens. Okay? Now within these, there are areas called pores of Kahn. And just like we had canals of Lambert attaching between adjacent terminal bronchioles connections, these are connections between adjacent alveoli. Okay? Pores of Kahn, canals of Lambert. Alternative pathways if there's obstruction somewhere along the line. Another nice picture that's showing how we have the pulmonary arteries coming down, pulmonary veins taking blood back. And you can see that we end up having these the respiratory bronchioles with some alveoli pouching out of them, some alveolar sacs, alveolar ducts, leading to the individual alveoli. If you want to think of it as a bunch of grapes with this mesh of capillaries surrounding around each individual grape. Now notice that they're also next to each other, proximal to each other, and there's all kind of interesting characteristics that happen as we inflate alveoli. They kind of all inflate together, which is interesting as they go along. Two cell types within the alveolus itself. We talked about the alveolar type 1, simple squamous, called a type 1 pneumocyte. Very, very thin, and comprises about 95% of the alveolar surface. The thickness of this wall is 0.1 to 0.5 microns. That's damn small. I mean, we're talking 1,000 times thinner than a piece of paper. Okay, this is film that is there. In addition to those type 1, there are type 2 cells. And alveolar type 2 cells are cuboidal, and they secrete a substance called pulmonary surfactant. Okay. And pulmonary surfactant is critical for life. It reduces the surface tension and keeps the alveoli stable. And when we get to that part, you'll start crying. But it'll be okay. We'll get through it. Okay. But it's critical for life. Type 1, type 2. Roughly, and you'll find variants in different texts on this, but it's somewhere around 300 million alveoli. Okay. If you were to take all the alveoli and peel them apart and lying flat, it'd be the size of about a 75 to 85 square meters, the size of a tennis court. A tennis court is inside your chest. You know, they say the skin is the largest system. Nonsense. It's the lungs. It's huge. It's a miracle that we have this ability to exchange that much gas. Just the way the good Lord made us. 35 times more surface area than the skin. It's a fascinating structure. Okay, we talked about the pores of Kohn being connections between adjacent alveoli. There is an alveolar type 3, type 1 gas exchange, type 2 secretion, type 3 garbage collectors. If for some reason some particle gets down there, there's no cilia to take it away. We've got to have a macrophage. Comes in and eats it up. In between adjacent alveoli and the capillary network is an interstitial space, which is basically just a jelly-like substance. Okay? And there we can end up seeing how the pulmonary arteries and pulmonary veins branch into this capillary network which surrounds the alveolar structures. The capillary that is there is wide enough for an erythrocyte. They go through single file. Ain't a whole lot of space involved there. You can see the type 1, type 2 in the alveolars, macrophages there. It's just another radiograph on it. I'm trying to think of how much more I got here. You guys holding on okay? Okay. The lung itself runs from the diaphragm to just above the clavicles. And if you remember the clavicle itself, the first rib is behind the clavicle. You can't actually feel your first rib. The first rib you palpate is actually your second rib. The first rib's tucked behind. But your lung actually goes behind that. So it's actually behind the clavicle. The top of it is called the apex, and it's kind of pointed, obviously, because your thoracic cage changes in shape. The base of the lung is somewhere around the sixth rib or xiphoid process anteriorly, so this is where the lung ends. And if you follow your ribs to the side and posteriorly, the lung actually gets larger and goes deeper. So it's about the 8th rib laterally and the 11th rib posteriorly. So it's kind of a dome shape wrapping around the diaphragm. Right lung is larger and heavier than the left, just because it's a bigger structure. You got the flipping heart in the way. And here you can see 6th rib anteriorly, 8th rib laterally, and if we go to a posterior view, it's about 11th rib on the back. All right. Right lung, we said it had 3 lobes, uniquely named upper, middle, and lower. and it has 10 segments. The left lung has 2 lobes, upper and lower divided, and it has 8 segments. And those lobes are divided by what we call fissures. You can actually, if you were to open up the chest, slide your hand in between the individual lobes of the lung. There's 2 fissures on the right, 1 fissure on the left. You can see these fissures that are located there. Okay. Here's a horizontal and an oblique, and the left only has 1. Okay. It's a pretty picture. Okay, here's the bad news. You're going to have to memorize these. Okay. Now, the reason being, and this will happen next semester when Mary talks about something called postural drainage and chest physiotherapy. For certain patients, they have a decreased ability to remove secretions. Their ability to cough is ineffective, or they just have such massive amount of secretions being produced that they can't get them out. So we have to do things like hang them from the ceiling, not really, but using gravity to facilitate drainage. Well, if you look at the tracheobronchial tree, it doesn't all branch downwards. Sometimes it branches upwards. So we need to position them in different positions based upon the segment involved. So what you'll need to know is that there are 2 lungs. The right lung has 3 lobes, and what makes up those lobes are the individual segments. Right upper lobe, apical, anterior, posterior. The middle lobe is divided into the lateral and medial. The right lower lobe is divided into the superior, anterior basal, medial basal, lateral basal, posterior basal, ricculumi. Easy way to remember these: palms. Posterior, anterior basal, lateral basal, medial basal, superior. Left lung, the upper lobe is broken up into 2 divisions. The upper division, and notice what it did is it kind of took 2 of the segments on the right and branched them together. So it has an apical posterior segment and an anterior segment. And the upper lobe lower division is known as the lingula. Love that word. Lingula. And there's a superior lingula and an inferior lingula. And in the lower lobe on the left is slap, or pels, or alps. And again, all they've done is join the anterior and medial together because the damn heart's in the way. Okay. So at some point over the next whenever, you'll need to memorize these. Because I might ask a question saying all of the following are in the left lower lobe except. Talked about those fissures, oblique and horizontal. Oblique is located on both sides. Horizontal is located only on the right. So here, if you look at this picture, this obviously, there's my horizontal fissure, there's my oblique fissure. Okay? Horizontals are located only on the right lung. So here's my upper lobe, horizontal, oblique. A couple of terminology. Hilum is the area where everything enters into the lung. If you think about it, when it branches off, the aorta branches into the bronchial arteries, the nerves, and all that stuff, where it enters in through adjacent to the right and left main stem bronchi, it's called the hilum of the lung, and that's the medial border of it. So it's this part here. And just another view of it. And you can see where those segments are located, and they're nicely colored. And there's pretty pictures. I think I have this one on my website, kind of a pretty picture that you can end up seeing what they're looking like anterior and posterior, or if the lung is turned a little bit one way or the other. So I'm called to the ER to manage a code blue. Physician intubates the patient, and I only hear breath sounds on the right side. What do? Pull it back. Don't have to pull it out. Just pull it back. Okay. that right? 9/10 or 9/11? Is that the date we're having the exam in here? So it's a week from Monday or Tuesday. Okay. And I think I got a study guide up there as far as what's on it, but we're back on schedule now, so we should be okay. Let's do a little review. What do we call foreign matter entering the lung? Aspiration. Where is it? Base of the tongue. Where is C1? The base of the skull, right? I don't think your trachea is up that high. I'm going to go out on a limb here. T1, T10 is a little bit too low. T5 to L1 is obviously ridiculous. It'd be somewhere in your stomach someplace. C6, T5 is correct. How should the vocal cords be when we're extubating? Ab or ad? Abducted. You want them open. Porzicon? Between adjacent alveoli. Okay. What do we call the respiratory bronchioles, alveolar ducts, alveolar sacs? It's the word we have for them. The gas exchanging units. Acinus, primary lobule. And collectively, we call them all together the parenchyma. Hilum is located on which surface? Medial. Unpaired cartilages? I know we just went over this today, so it's kind of unfair. Retinoid, cuneiform, and corniculate. Oh, I'm sorry, unpaired. Thyroid, cricoid, and epiglottis. This is one of the things that I do for some of these things. Play a little Jeopardy, final Jeopardy question. How much do you want to wager? Type 2. Type 1 is dealing with what? Gas exchange. Type 3 is dealing with what? Cleanup, garbage collection. All right.